Hello. In our last episode of Health on the Line, we discussed the model ICB blueprint that had just been published. We did that with two leading ICB leaders who'd been part of the working group that helped to develop that model ICB paper. Well, the dust has settled a bit now, and we're getting to grips with what this means for the whole health and care sector. With change coming thick and fast on top of that work, and ahead of what will be a milestone moment for the NHS with the publication in a few weeks' time of the 10-year plan. So over the next couple of episodes of Health on the Line, and ahead of Confed Expo, also taking place in just a couple of weeks, we're going to be talking about what these changes for ICBs mean to leading figures within the Confed who spend time every day talking to leaders throughout the service. What are the changes in ICBs, the overall context of the health service? How are they impacting? And what other changes are particularly important for the people that they work with? Today, I'm delighted to be joined by Rory Deighton, who's director of our acute network, and Ruth Rankine, who's director of our primary care network. So, Rory, I'm going to start with you, and partly because yesterday you hosted the first meeting of our new acute advisory group with a number of leaders from across England, and I was there, and we talked a bit about questions around the operating model. And of course, this week, the Confed itself has published a really strong paper, I think, with our principles, what we think should guide the operating model of the NHS going forward. So, Rory, from your perspective, how are acute leaders in particular thinking about the changes that are taking place in ICBs and what this means for themselves and for the system as a whole?
Thanks, Matthew. So I think that acute leaders are welcoming the simplified landscape that the new operating model represents. I think they're really enjoying the plain speaking that we're getting from Jim Mackey at this point and his leadership team. I think that the revised operating model gets over some of the frustrations from last winter where they felt performance managed from almost every angle, from ICBs, from regional teams, from national teams. So I think generally welcoming the direction of travel and the simplification and the long-term perspective that the new operating model suggests. I think any concerns come in about pace and whether we have practically factored in the costs of the changes that they're being asked to deliver over the next few months and years. So how the responsibilities are shifting out of ICBs into providers, I think is an area that feels quite uncomfortable at the moment. There's an ongoing debate about where responsibilities are going to land. Are they going to go into a provider collaborative? Are they going to go into trusts? Are they going into an accountable care function at a place? So those sorts of issues are live discussions that leaders are having on a day-to-day basis at the moment. And somebody described it yesterday as feeling a little bit like tick box bingo at the moment, with leaders not wanting to lose bits of the system, but also not wanting to land grab for responsibilities that might not have any resources that go with it. So I think there's a concern about that and the practicalities of making these shifts come out of ICBs and how these responsibilities are coming out of ICBs at the moment.
Yeah, and of course it's important to remember that acute providers themselves are being expected to cut back on their own operating costs. So, they're making these changes at the same time as they're bearing down on that. Ruth, let me turn to you. You represent primary care. Primary care can sometimes feel quite a long way away from what's happening at the kind of system level, but the people who are particularly active in our primary care work are the kind of people who do get involved in place and system leadership. What are you picking up from primary care about their response to the shifts in the policy around ICBs?
So we've had lots of conversations with members on this, obviously, since the document was published. And as you say, our members tend to be those that are more innovative anyway, and sort of always thinking ahead and thinking about the opportunities. So I would say at the moment, there's cautious optimism. People see the opportunity for primary care to play a really important role, not just at that local level, but at that place level as well. I mean, I think that obviously the day-to-day sort of workload and pressures and financial challenges don't go away, but there are people who are seeing this as an opportunity to actually realise left shift, realise more investment into primary and community services. So they are now actively thinking about what is it we need to do to build that infrastructure, to realise those opportunities and to be a key player in all of this.
Yeah, that's really interesting. And Rory, I sense almost a tension in the way in which, at one level, the 50% cut in ICBs seem to speak to a kind of downgrading of their role and their significance within the service. I've heard people kind of say, well, is this the end for kind of system working? But yet, having said that, we know that actually systems have got a really important role to play in determining with providers what the provider architecture is going to be between system and neighbourhood. There are a variety of models in terms of who might be the lead provider. And then also, fascinatingly, this week we've heard, Glenn Burley, obviously an acute leader himself, but now working with Jim Mackey and the national team, talk about the responsibility of ICBs in relation to demand management, reducing the pressure at the front door of the hospital and reducing elective demand. So when I spoke to your acute leaders yesterday, I kind of said it sometimes feels a bit contradictory. ICBs are in the middle of reorganising and cutting back, but yet their role in developing that provider architecture, their role in trying to do something about reducing demand seems to be even stronger. Now, I felt that was a bit of a tension, but actually your leaders felt this was a really good refocusing of ICBs, didn't they?
Yeah, I think it's a really good example. I think provider leaders are really comfortable with the additional accountability, or with the focus on personal and board accountability and provider accountability that Jim Mackey has signalled over the last few months. I think they're really comfortable with that, and they're really comfortable, if we look at elective recovery, at the clear target they've been set for the end of the year. We can talk a little bit about what targets might look like in years 2, 3, 4 of this parliament, but really clear signals and really clear messages about accountability. What it's hard for them to be accountable for is the growth in demand that's coming from their communities, and in particular the variable growth in demand. The piece in the HSJ this week and the work that Glenn Burley has been talking about showed vastly differing growth in demand in different parts of the country, and it's tackling that variation that Jim Mackey is quite rightly interested in. And I think the role of tackling that growth, it is a role that is naturally suited to the ICBs, and I think the ICBs have a really important role there. That relationship between primary care and secondary care, that interface between the two, how you manage the pipeline of demand in between primary care and secondary care, and you ensure that those referrals are coming through that are appropriate and are right, and how you build better relationships between primary and secondary care. Those are really valuable things that ICBs can work on with providers and with primary care.
Ruth, you've played a number of roles. You've been involved in health policy in lots of ways over the years. When you look at the pace of change, the change at NHS England, the change in ICBs, I mean, what Rory outlines, what the acute leader said yesterday, you can see the potential, but yet we're dealing with a level of change in these organisations. It's quite hard, isn't it, to focus on what really matters when your organisation's going through so much change?
I think that's right, but sometimes you need a sort of a shock factor in situations like this to really force people to think completely differently. And I think we've seen that with the NHS England announcement and the ICB announcements. And, it's massively disruptive. And we know this because we're talking to members in all parts of the system, the risk is that people are focused on what's the new structure and what's my role in the new structure. And that can sometimes take people's focus away from actually thinking about the day job. But on the other hand, I think that the scale of the change that we're seeing focuses us to think really differently about what is the role of different parts of the system, with that focus, as we talked about in our report yesterday, in terms of how do we get that real focus on communities? How do we get this locally led? And when we say locally led, we're not just talking about local ICBs, local providers, but it's all about how we're working with local communities. And that is true bottom up, locally led, so that communities and the voice of communities is built into everything that we're thinking about in terms of how we redesign services, where services are delivered. I'm not disputing this is not massively disruptive, but I do think it does give us an opportunity to completely rethink the model of care.
That report, by the way, that you mentioned is a report, A New Operating Model for Health and Care, and people can find that on the NHS Confederation website. It is a really strong document. I want to return to some of these issues in a moment, but just before I do that, obviously both of you spend a lot of time day in, day out talking to leaders. So just standing back from the kind of operating model, in a moment I want us to talk a bit about neighbourhoods. What more generally is going on within your sector? So we were talking yesterday, weren't we, with the acute leaders about, the government has agreed to pay increases for staff which go beyond the amount of money that's been allocated. What would you say when Rory, you're picking up as being the key issues for the leaders you represent at the moment?
So let's start off with that pay issue, and that links directly into finance, and then we'll talk a little bit about elective recovery. And urgent and emergency care is a really strong theme for us at the moment. So the pay awards yesterday, or the announcements yesterday, the key thing I think short term will be waiting to see how much of that pay award they will need to find from within existing budgets. And I think there'll be people with their fingers crossed today, hoping that over the next week or so, some additional money will come out of NHS England to fund at least part of that pay award. So that's the short term. Of course, the long-term aim in terms of pay is linked to the comprehensive spending review and making sure that the comprehensive spending review effectively backs and supports the workforce plan. I think for many leaders, the issue about agenda for change, where increases in the minimum wage, which are fantastic for the country as a whole, come into conflict with the agenda for change pay scales. I think there's a short-term and a long-term pay issue there. For elective recovery, I think this year's target of 65% is achievable. I think the concern will be that as the targets ramp up over year 2, 3, 4, 5 of this Parliament, moving towards that target of constitutional standards by the end of the Parliament, I think that's really tough. And I think we have had 6 months worth of making some progress on elective recovery, a slight dip in this month. That's going to be a really tough thing for leaders to work on. Really strong link between their financial position and achieving financial balance and delivering elective recovery. So lots of focus on those areas, but I think it's going to be really tough. And those comments that Glenn Burley's making about demand growth and demand management are really important in that context, I think. I think the biggest issue, and the issue that I think Confed will start talking about a lot more, and the issue that the government, I'm not sure, is getting entirely right at the moment, is urgent and emergency care. And I think there's a lot of concern from leaders that we're not quite giving urgent and emergency care and emergency department waiting times the profile that they should be getting. And I think there's significant risk ahead of next winter, and significant risk in terms of public perception and patients' experience in the ongoing issues around corridor care, the use of temporary escalation spaces, whether they are in the back of an ambulance or in a temporary ward, and the circumstances in which patients are waiting for emergency care. I think that's an area that will grow in profile, quite rightly so, over the next few weeks and months. And I think it needs more focus than we're giving it at the moment.
Yeah, no, I really picked up on that point that the leaders were making to us yesterday. Rory, of course, we're still waiting for now kind of quite long delayed UEC plan. But yeah, and I was taken by the leader who felt that the government had kind of got wrong what the public most care about. That, of course, the public care about those people who've been waiting a long time for elective care. But actually, the impression that is given by A&E departments with people in corridors and people waiting 12 hours, that more powerfully undermines people's confidence in the NHS. I thought that was an interesting observation. Ruth, turning to you, I think one of the interesting things about the work we do with primary is that because we consciously work with primary leaders who are entrepreneurial and progressive, want to work at scale, that there's always a little bit of a danger that we get slightly detached from the fact that day-to-day primary is still under immense pressure. I heard the other day about, in one part of the country, a GP role had been advertised at £100,000 a year for 2 days a week, just because it was so incredibly difficult. That's not pro rata, that's for the 2 days. So incredibly difficult to attract a GP to this particular part of the country. So kind of standing back from the work that we're doing around the kind of 10-year plan and reform, how do you see the general state of primary at the moment?
I think it's incredibly challenging. And, let's be clear, when we're talking about primary care, we're talking about all aspects of primary care. So general practice, community pharmacy, dentistry and optometry. But in the case you've talked about in terms of general practice, we know that we need more GPs. Wes Streeting talks a lot about return to the family doctor. And if you talk to GPs directly, they would say, we want that personalised relationship with our patient. We want to be able to give continuity, but we can't do it in a 10-minute appointment, and we can't do it with everything else we're doing, and we can't do it because we haven't got enough doctors. So I think it is a massive challenge, and the pipeline coming through is not necessarily going to meet the needs of the future demand coming from the public, or indeed the future expectation of the public. So I think in remodelling this, and particularly around a neighbourhood health service, we're going to have to get that balance right between public need versus expectation, and actually what the service can provide, and thinking about using our workforce differently. So there is a really critical role for GPs, but equally there is a valuable role for other members of the team. So working as part of the neighbourhood team, because a lot of what's coming through the GP door, and to some extent the A&E door, are health needs, but the causes of those health needs are because of wider social issues. So, the whole focus of neighbourhood working in terms of not just addressing the health needs, but starting to address the causes of those health needs, which are not the responsibility of the NHS to necessarily resolve, is a really important one. So hopefully, if we get that right, that will help to manage some of the demand down that we're seeing within the NHS. But I think the other thing that we need for GPs is a good career pathway. So there are massive opportunities through left shift and neighbourhood for GPs to undertake slightly different roles. We're already seeing that now with GPs with an extended role or a special interest, GPs leading neighbourhood teams. So I think we've got to think about that GP career pathway so that it protects those that want to just work in general practice, but equally, if you think about the new GP coming through, they want a slightly different portfolio career. So I think we've got to think about recruitment and retention, and workforce is a really critical part of all of this.
So Ruth, as we kind of draw to a close, let's talk about neighbourhoods. And I'm really glad that you made that point, because it feels to me as though there's quite a big part of the story that we're not really telling the public, and we need to tell them more, particularly ahead of the 10-year plan. And that is over-medicalisation. It really wasn't much mentioned in the kind of Darcy review. We don't talk about it a great deal. And I guess maybe because for the public, they focus on access. They focus on the idea that the public isn't getting enough from the health service. But yet there is arguably an equally big problem, which is that we are giving a lot of people kind of medical care which isn't really helping them a great deal and isn't really addressing the problems they've got. I was in Watford on Monday talking to the trust there. Really, incredibly impressive work. And they gave me a presentation about their work at Place. And they're doing work around the frailty pathway. And they've got a really ambitious and, well evidenced approach in which they think they can really substantially reduce the number of older people who end up needing acute care by developing a more holistic model, providing more care in the community, but also exactly as you say, often recognising that what people need is not actually medical interventions, it's help with other parts of their lives at that stage. Do you think that in the neighbourhood model, we ought to be being more open, more explicit about the fact that part of what we're trying to do here is to avoid people having medical solutions to problems that actually need other kinds of intervention and support?
That's absolutely the ambition and where we need to get to. I think where we're starting, and let me be clear that this type of approach, whether you call it neighbourhood working, multidisciplinary teams, it's not new. It has been going on for a long time. But essentially what we're doing now is formalising it. And we're saying, we recognise the value of this model and we want to see it across the country. But I think where we're starting in terms of the priority, obviously linked to the demand that Rory has talked about and that we're seeing in acute and seeing in primary care, is the likelihood was that we will start with that sort of, top 5% of people that are touching the NHS several hundred times during the year, where actually the sort of high complexity, high need. Now, in those cases, actually, they may be more health focused, but I think as we trial that model and get used to working in this way and start to then think about, ICB, new role around population health management, thinking about the needs of communities, the role of neighbourhood health providers and really understanding the community needs and building those wider partnerships outside health, then the ambition has got to be really building those partnerships as key components of the delivery of the end-to-end pathway for those people, whether that's an NHS provision or whether it's voluntary sector or whether it's housing or education. So I think that's the ambition. But because of the pressures on the system in terms of demand, we have to sort of start where we will have most impact on NHS services. That's not to say people are not already working across boundaries already, but I think in terms of that national drive, it will be around where we can have most impact on reducing demand on the NHS.
And then, Rory, I think that in earlier conversations about neighbourhoods, there was a sense amongst acute colleagues that they weren't really being seen as part of the picture. And I remember actually, a few weeks ago, you organised, didn't you, a conversation with acute leaders about neighbourhood working. And sometimes from outside the acute sector, there's a concern that when acute leaders say, well, look, we want to be part of this, work at neighbourhood level, that it's a kind of acute takeover. But, that's not the sense, I've got talking to your leaders. Of course, many of the acute leaders you represent are also running a community services and some of them primary services as well. What's your sense of the ambition amongst your members when it comes to neighbourhood working?
I think there's a wide level of support for the concept and for the idea of neighbourhood working. And at Confed, we are 100% behind the idea and we are really convinced of its benefits. I think we need to work harder to bring all of our acute members with us. I think there is an ongoing debate on the evidence base for neighbourhood care. I think Ruth's point that we need to be starting with neighbourhood working that can demonstrate an impact on the rest of the NHS. It's perhaps not the social model of care that we aspire to long term, but I think it's a practical first step on that road towards closer working between primary and secondary and community services. I think it's a sensible thing. I think there is a nervousness that we are putting quite a big bet on neighbourhood working and that it could go one way or another. I think we have that ambition that it could reduce the over-medicalisation that you've talked about and move to a lower cost setting, and that's to everybody's benefit. But it could end up with huge choice for patients and a growing cost base. So unless we get that evidence base right, I think we might struggle to take some of our acute members with us. The other thing about taking people with us, and Jacob Lant at National Voices talks about it really well, he believes that we need to get the basics right before we open up the neighbourhood conversation with our communities, that we need to be getting urgent and emergency care right, GP access right, elective recovery right. We need to be earning the right to have the conversation about a new neighbourhood-led NHS. And that until we start to get those basic building blocks in place, we're going to struggle to have that wider conversation. So I think that's that link, I think, as Ruth has just described, about why neighbourhood working needs to link into the acute sector and needs to be able to show a benefit to the acute sector in terms of urgent emergency care and elective waiting. I think it's a really important link.
Yeah, and I guess that speaks to one of the issues around the 10-year plan, which is this kind of sometimes referred to as the 3-7. You know, the first 3 years of the plan will be about recovery and laying the foundations for reform, because realistically, some of the bigger shifts that we want to achieve, particularly in relation to kind of working with the public expectations, can't realistically progress until we have addressed those foundations. The danger, of course, with that is that tomorrow never comes, but we'll find out more as that 10-year plan emerges. Now, it's been fantastic talking to you both, Rory and Ruth, but I'm going to put you on the spot because, of course, we're a membership organisation. We've got our huge conference with NHSE coming up in a couple of weeks, bringing all our members together. That'll be a great event. But I'm going to ask you, as we close, to do an elevator pitch. Rory, why should acute trusts join the Confed?
Well, because the future is all about system working. It's about integration. It's about place-based working and neighbourhood-based working. And providers are the drivers of change now. Jim Mackey and the Secretary of State have made it really clear that integration and change will be driven by provider organisations. The Confed is the place that you can come together with your primary care colleagues, with community trusts, with your mental health colleagues and your ICBs, to have those conversations, to see where things are working well and to learn from your peers. So that's why the Confed is in a particularly important place at the moment. Thanks, Matthew.
Thanks, Rory. And I do think, Ruth, that whatever happens in the 10-year plan, actually so much is going to rely upon the quality of local relationships. We're going to have to solve these problems on the ground amongst leaders themselves. Tell me why primary leaders should be wanting to join the Confed.
Well, I said to a group of our members the other day, the time is now for primary care. There's a massive opportunity for people to step up and lead this. And our job at Confed and through the primary care network is help people to do that. So bringing like-minded people together to learn from each other, to support each other, and really to just understand what the different models are that are currently out there and what ideas can they take from those and what can they take back into their system. This isn't a one-size-fits-all. But next week after, we're just starting a series of webinars on different primary care collaborative models. So we will be bringing people in from different parts of the country to talk about what they're doing, how they've done it, what their ambition is, what benefits they're realising. And a lot of that will be about how they're working in partnership. So for me, it's just bringing people together to learn from each other. Also, we've got our relationships with the department and NHS England, and that's really critical at the moment in terms of influencing not just the 10-year plan, but obviously the implementation of the 10-year plan, which will be just as important as what the plan says.
Yeah, thanks, Ruth. And, some of the things I get most excited about at the Confed is when we bring different parts of the service together. We launch, for example, this week a new year-long collaborative between mental health trusts and acute trusts, focusing on the kind of mental health A&E interface. And, that was a great event.
I think on that, though, Matthew, the report we published yesterday was a great example of where we got people in the room across all of our networks. And what struck me was just the similarities in the conversation that people were having. Whether it was acute and primary or system mental health, which then informed the report we produced yesterday. So, as Rory says, in a future world of better partnerships and more integrated working, I think that's the benefit of being in Confed, is being part of that bigger conversation.
Ruth, thank you so much. Rory, thank you so much for your insights. If you want to know more about our acute or primary care network, then do go to our website, nhsconfed.org, for more information, or come and see us on our stand at Confed Expo from the 11th to the 12th of June in Manchester. So that just leaves me to introduce our latest Leader in Six interview, and this time it's with my good friend Daniel Elkeles. We recorded this a few weeks ago at our Care Closer to Home conference. We recorded it just before he finished as CEO of the London Ambulance Service, and we, of course, wish him all the best as he starts his new role this week as CEO at NHS Providers.
Question number one, in your LAS role, what is top of your kind of inbox right now?
Top of the inbox is, how can we, in the year we're now in, take less and less people to hospital by getting the right care for them when they phone 999?
Brilliant. That's what we're going to be talking about in a session here in just a few minutes. Second thing, what single innovation, I came to see the loads of innovations, but pick one innovation in LAS you're particularly proud of and pleased about.
I'm really proud of answering the phone for 5 GP practices for the patients who are phoning their GP practice saying, I'm not feeling very well today. What should I do? And getting my 111 call handlers to be GP receptionists. And we've managed to find a way for about 20% of the patients, taking them out of primary care. And for the patients who need primary care, getting them an appointment in the timescale that they actually need it in. Huge satisfaction from GPs, from GP receptionists, and from patients.
Yeah, and one of the things I often quote from you, Daniel, to take this inspiration to the way you describe one of the core functions of LAS is helping primary care do what only primary care can do. Third question, if you were king of the NHS for a day, what's the one thing you'd do?
I would absolutely celebrate GPs, because if we don't love what primary care does, we will never sort out the NHS.
What a great place to say that, Daniel. Question 4. Tell us about a leader you particularly admire. Could be historical, could be global, could be local.
Well, clearly it's you. But I also think that Jim Mackey is a pretty inspirational leader. And then at the beginning of my career, I had a lot of contact with Peter Homer, and I think he is pretty inspirational as well.
Tell us a bit more about Peter.
So Peter is one of the most compassionate leaders I've ever met. And he gave me the advice, which said, you need to set a really bold strategic vision of where you want to get to, but then be really proud if in the time you do the job, you make some steps along the way to get there. And that is just as important as getting to the end point.
Absolutely. The longest journey starts with a single step, I think, is a bit of Chinese philosophy. So, penultimate question for you, Daniel. Tell us one thing about yourself that is interesting and is nothing to do with the day job.
Well, as you know, I've just run the London Marathon, and I was inspired to do that because it's the biggest event LAS puts out people for every year. And for the last 4 years, I've been to see all the teams and trying to walk around the course again and say hello to them all. And I thought this would be much easier if I actually ran it. So I spent 9 months training my body to be able to run the marathon. And I'm really proud to say I completed it this year.
Well done, and particularly because it was a hot day. You didn't train in that heat, did you?
No, it was a very hot day. And I think there were rather a lot of casualties as a result. So I think St John and London Ambulance were very busy.
Brilliant. And then last but not least, share a bit of content that you've enjoyed recently, you'd recommend to other people. A book, a podcast, a film, a TV series, anything.
I'm going to say about 2 TV series. They're both on Apple TV, plug Apple. So one is Slow Horses,
Our slow horses. We all love slow horses.
And then the other is Severance, because, oh my gosh, you could really think that could be the future, and it's very scary.
Well, Daniel, it's eerie that you've chosen two of my favourite TV series. We are going to be able to work closely together in our roles. Thank you so much for doing this.
Thank you, Matthew.
Health on the Line is brought to you by the NHS Confederation and is available on Apple Podcasts, Spotify, YouTube, and many other outlets. For more information and insight into the issues covered in this podcast, visit nhsconfed.org.